and genitourinary system specific to the pediatric population. So with a UTI, UTIs are more common in uncircumcised infants just because there can be, of course, a more collection of bacteria there that could cause an infection. You want to educate the parent on the importance of hygiene, so making sure the child is wiping from front to back. And then children may be asymptomatic of a UTI, so early screening is very important to prevent any complications. Glomerulonephritis. So glomerulonephritis, it's characterized by inflammatory injury of the glomerulus. So this patient is going to experience a loss of kidney function, pulmonary edema, heart failure, and even hypertensive encephalopathy can develop. So different causes. It can be caused by B. hemolytic strep infection in the pharynx or skin. You're going to see a history of pharyngitis or tonsillitis 2 to 3 weeks before the onset of symptoms. So acute glomerulonephritis will occur 2 to 3 weeks, usually after a strep infection, versus chronic glomerulonephritis, which may occur after the acute phase and then slowly over time. So the NCLEX may present a question to you saying that, there is a 7-year-old female with a history of tonsillitis 3 weeks ago. She's now presenting with a cough, pulmonary crackles, decreased urinary output. What do you suspect? And so glomerulonephritis would be your answer. So your assessment here. So decreased urinary output, they are going to have a lot of edema because their kidneys are not functioning. So they're going to have periorbital or facial edema that's more prominent in the mornings. The urine that they do have, they're going to experience hematuria. So the urine is going to be very cloudy, smoky, or brown colored. They're going to have a lot of proteinuria or foam in the urine. Then, of course, they're going to have increased BUN and creatinine. And then they will also have an increased anti-streptolysin O titer, which is used to diagnose streptococcal infections. Interventions for this patient: you want to assess fluid volume with daily weights. It is very important to remember that obtaining daily weights is the most useful and effective measure for determining fluid balance, okay? You're going to have this child always report any signs of bloody urine, worsening headache or edema, and then you're going to want to obtain immediate treatment. All right, nephrotic syndrome is a kidney disorder characterized by massive proteinuria, hypoalbuminemia, and edema. So the child is going to have elevated serum lipid levels, ascites, and edema. So nutrition education for this patient: if the child is in remission from nephrotic syndrome, they can have a regular diet but with no added salt. However, if they are experiencing massive edema from an acute case of nephrotic syndrome, they're definitely going to be placed on a sodium restriction. Okay, hemolytic uremic syndrome is a triad of anemia, thrombocytopenia, and kidney failure. So anemia, thrombocytopenia, and kidney failure. This syndrome is thought to be associated with different bacterial toxins or chemicals that could cause AKIs in children. It primarily occurs in children 6 months to 5 years of age. But remember that triad of anemia, thrombocytopenia, and kidney failure. You're going to see proteinuria, hematuria, the presence of urinary cast. The kidneys are damaged, so you're going to have an elevated BUN and creatinine, and then a decreased hemoglobin and hematocrits. The patient may even have hemorrhagic manifestations, including bruising, bloody diarrhea, jaundice, and then in very severe cases, CNS involvement like seizures, coma. So if this child is anuric, not producing any urine, dialysis may be warranted. A patient on dialysis is going to be placed on a fluid restriction just to make sure they're not fluid volume overloaded. And then you're going to need strict monitoring of the fluid intake and output. adequate nutrition, and then all of your infection prevention measures as well. So enuresis, is when a child is unable to control their bladder function, despite reaching an age where control is expected. So it's very important to remember that a child does not have control over enuresis. So there's primary, nighttime, daytime, and secondary. Primary occurs when a child has not yet mastered toilet training. Nighttime enuresis is that of bedwetting. Daytime is wetting that occurs during the day. And then secondary is the onset of wetting that occurs after an established period of urinary continence. So they've been potty trained, they've been continent for several months, and then they have the wetting again. That is secondary enuresis. If a child complains of any urinary abnormalities at all, they should quickly be assessed for a urinary tract infection. Remember, they may be asymptomatic of UTI, so if they're complaining of anything, they definitely need to get screened. The diagnostic criteria for enuresis is a child older than 5 years of age that wets their bed or their clothes 2 times a week or more for at least 3 months. Okay, that is diagnostic of enuresis. And then again, initially, it's very important to rule out any infection. You're going to want to limit their fluid intake at night. And then you're also going to want to involve that child in cleanup. So whether it's during the day with their clothes or at night with their bed sheets, you want to involve them in cleanup. And that will hopefully just help to progress them towards continence and control. All right, cryptorchidism. It's a condition in which one or both testes fail to descend through the inguinal canal into the scrotal sac. So the testes are not palpable or easily guided into the scrotum. Surgical correction can be performed between 6 to 12 months of age, but oftentimes this will spontaneously resolve within the first 6 months of life and does not require surgical intervention. Epispadias and hypospadias. So epispadias is where the urethral opening is located on the dorsal side of the penis, whereas hypospadias is where the urethral opening is located on the ventral side of the penis. So with epispadias, definitely know the difference between these. Epispadias is dorsal. It often occurs with a condition known as exstrophy of the bladder, which we'll talk about next. Hypospadias it's ventral, okay? So in male children with epispadias or hypospadias, circumcision may not be performed. Surgery may not be performed early in life. Surgery may be performed at 6 to 12 months of age because they may want to use the foreskin for reconstruction. And then bladder exstrophy. So bladder exstrophy, it's a congenital anomaly characterized by extrusion of the urinary bladder to the outside of the body through a defect in the lower abdominal wall. So immediately after birth, the exposed bladder is covered with a sterile, non-adherent dressing to protect it until closure can be performed. So again, bladder exstrophy, it's often associated with epispadias, and vesicouretal reflex, where the urine flows back up into the ureters. Initial surgery often occurs within the first few days of life for bladder exstrophy. And then you want to avoid applying petroleum jelly to the bladder mucosa because it tends to dry out. If it dries out, it will adhere to the bladder mucosa and damage the delicate tissues. So do not apply petroleum jelly to the mucosa. You just want to cover it with a sterile, non-adherent dressing.